Hello again. All right, so we're going to continue with our heart discussions, and we want to talk a little bit about fetal circulation and heart development. Um, when we talk about the heart, we've talked about blood flow, we've talked about how blood flows through the heart, but there are some differences in the fetal circulation that I want to go over, and we'll talk about this a little bit more when we do reproduction and fetal development. But there's some really neat things about the heart, and so you may not have thought about this. I want to point out some really unique differences between how blood flows in a fetus before it's born, and then once it's born and becomes an infant. And so when you look at fetal circulation, we have some really neat or different modifications. We have umbilical arteries and umbilical veins. And so you may remember you've got your belly button, and that's where your umbilical cord was. Well, the umbilical cord is actually made of arteries and veins. Okay, so that's how blood is moving from the placenta, which is attached to the mother's uterus, and allowing for exchange of nutrients, oxygen, carbon dioxide from the mother and the baby. So the placenta really acts like the lungs for the child. So when the infant is producing waste products, it's going to be carried through the umbilical cord, the umbilical arteries to the placenta, and then nutrients are going to be returned to the baby through the umbilical veins. All right, so think about that. Arteries away from the heart, veins to the heart. So in this case, in the fetus, are the arteries oxygenated or deoxygenated? Are the veins oxygenated or deoxygenated? Think about it. I'm going to show you a picture, but just think about it. It might not be what you think. All right. You've also got some shunts. There are some ways that you can shunt blood and bypass some things, because think about it. The fetus isn't using their lungs, so we can bypass those. The placenta is doing a lot of work for the baby, so the mom's really doing the work for the baby. So we're gonna bypass some things. You have what's called the ductus venosus, and it bypasses the liver. All right, because the placenta is going to act like the liver. It's going to do that detoxifying job that the liver would typically do. The placenta does that. And so you have the umbilical vein that travels, the blood then goes to the ductus venosus and then into the inferior vena cava. You also have two shunts that bypass the pulmonary circuit, that bypass the lungs, the foramen ovale and the ductus arteriosus. The foramen ovale is an opening between the two atria, and the ductus arteriosus is a shunt that bypasses the lungs by moving blood directly from the pulmonary trunk to the aorta. All right, so let's look at what that looks like. So here is the fetal circulation. So remember, the infant is inside the mother, inside the womb, and so the baby and mom are connected by this placenta. So this is the placenta, and it attaches to the uterine wall. And so there's no actual mixing of blood, but the maternal blood and the fetal blood is close enough that exchange can occur. So nutrients and oxygen and carbon dioxide can move between the uterus and the mother. So the placenta is acting as the lungs and really the kidneys and the liver. It's really doing all the job that the removing waste products. The kidneys are functioning in the infant, but the mother is removing waste products for the infant. All right, so the way this looks is, so here's mom over here. We're going to draw a uterus here. So let's say oxygen. So mom's breathing in, oxygen's going through the bloodstream to the uterus, and it's going to go into the placenta. For it to return to the baby, so it's the oxygenated blood, it's got to go back to the heart. Is that an artery or a vein? If it's going to the heart, it's a vein. So these bright red things, these oxygenated vessels, these are actually, this is the umbilical vein. I think I have this here somewhere, hopefully. I think it's umbilical cord, umbilical arteries. You should be able to see umbilical vein. Oh yeah, here it is, sorry. This bright red is the umbilical vein. Okay, so it's returning blood to the fetus, to the fetus's heart. All right, so it's going to travel up the umbilical cord to the umbilical vein, and then there is a shunt. It bypasses the liver because it's already been kind of cleansed and taken care of. It doesn't really need to go through the liver because you're not eating You're not exposing blood to the things that you do when you think about blood that's gone to to the stomach and the liver, like the hepatic portal system. Hopefully, you remember a little bit about how blood flows through the hepatic portal system. You can bypass that, so the blood goes straight into the vena cava. All right. So now, if you'll notice, you've got returning bloods. Venous blood from the rest of the fetus's body that's also got to go back to the heart. So you have this deoxygenated blood mixing with oxygenated blood, so it kind of turns this purple color, this moderately oxygenated blood. And this moderately oxygenated blood is what goes into the right side of the heart, the right atrium. It then goes into the right ventricle, and then just like you expect, it's going to be pumped to the pulmonary trunk. But you don't actually need to send that blood to the lungs because they're not going to do anything. There's no oxygenation, deoxygenation going on. So you have something called a ductus arteriosus, which is an actual tube or shunt between the pulmonary trunk and the aorta, so that blood will go straight to the aorta and then out to the rest of the fetal circulation. Now, some blood does go out to the lungs. It's not completely bypassed, okay? So the pulmonary trunks are actually working, okay? So some blood's going out, but not as much as you would think. So that blood's going to return to the left side, and that's going to be pumped, as usual, out the aorta. So you have a mixing of that blood that was shunted from the right side plus the blood from the left side, goes into the aorta, all right, and then travels to the rest of the body. So body vessels going away from the heart are called arteries. And you'll see this blood is pretty low oxygenated, okay? So this is the low oxygenated arterial blood that's going out to the rest of the body. All right, so these arteries are then going to go into the umbilical cord as umbilical arteries. They're going away from the heart. They're low oxygenated. And then they're going to go back to the placenta and be reoxygenated. That blood will come back to the fetus as an umbilical vein. So just like in the lungs, with the red things with the veins and the blue things with the arteries, in this case, in the fetal circulation, the umbilical vein is red because it's highly oxygenated. It's bringing oxygen from the mother. The umbilical artery is going to be kind of a low oxygenated pink color because it's taking that low oxygenated blood back to the placenta. Now, the blood that's coming out to the different tissues, going through the capillary, and then returning as venules and veins into the vena cava, that's going to be your typical blue deoxygenated blood. Okay, so you have 3 shunts that allow for you to bypass the liver and the lungs. Okay. So once the infant is born, okay, so they take that first breath, and there's some physiologic changes that occur, and within the first 24 to 72 hours, those shunts are going to start to shut down. Well, the first one that shuts down is you cut off the umbilical cord, okay, so that prevents any more arterial blood and venous blood from reaching the placenta. So now you've taken away the job of the placenta to act as the lungs and the liver, okay. So that's going to cause some physiologic changes. And so what remains, you're going to have your belly button, okay, where your umbilical cord was, and you're going to get these umbilical arteries are going to lead what are called these medial umbilical ligaments. So you're actually going to see the remains of those arteries are still going to be there. So if you were to dissect into a cadaver, you could actually see these remains. It's like just fibrous tissue. And then the umbilical vein is going to remain as just this piece of tissue called the ligamentum teres. All right, but they're no longer carrying blood, so they're just basically they're just empty vessels that are now kind of turning into some like scar tissue almost. All right, and so the other thing that happens, because this is going to be immediate because you've shut down the umbilical cord, so there's no need to use that shunt anymore to the placenta. All right. So now the next thing that happens, because you're getting changes in oxygen levels and pH levels and just these whole physiologic changes that occur at birth, the fossa ovale will close. There's no need to shunt blood from the right side to the left side. We don't need to bypass the pulmonary circuit anymore. So now the blood will go like it's supposed to. It'll all go from the right atrium down to the right ventricle. It'll go out the pulmonary trunk, Well, again, we don't need to bypass the lungs anymore, so the ductus arteriosus will basically shut down and turn into the ligamentum arteriosum. So your foramen ovale turns into your fossa ovalis, and your ductus arteriosus turns into your ligamentum arteriosum, and so your shunts are now, you've stopped those shunts. You're not bypassing the lungs any longer. All right, so your little hole in the heart between the left and right atrium is now gone, and the shunt between the pulmonary trunk and the aorta is now gone. All right, that's what should happen. Sometimes it doesn't. So if you have a birth defect, you may have a patent foramen ovale and a patent ductus arteriosus. Patent means open, so like a patent airway is an open airway, an open trachea. So what does that mean if you have a patent foramen ovale or a patent ductus arteriosus? So if you have a patent or open foramen ovale, that hole between the left and right atrium is going to remain. And it's not the worst thing. It's not the worst birth defect you can have. And they may not do anything, and it may resolve, but it's not life-threatening. You may have some poor oxygenation. You may have some poorly oxygenated blood in your system, but it's not life-threatening. What's going to happen is because you've got that hole, the left side is a little bit stronger than the right side, so you may have some mixing of blood back and forth between the right and left side. So you may get some mixing of deoxygenated blood going into the left side and some oxygenated blood going into the right side. But again, it's not that big a deal. They may or may not fix it. Now, patent ductus arteriosus, this can cause some problems. This is really common in premature infants because they're born too early, and so what will happen is that patent ductus arteriosus will remain open, and remember, it's the little shunt between the pulmonary trunk and the aorta. And so now your right ventricle is pumping deoxygenated blood right into the aorta, and so you are going to get more mixing of deoxygenated blood and oxygenated blood going into the aorta, which can lead to poor oxygen problems in the periphery. Okay, so a patent ductus arteriosus would be more critically and more in more need of repair than a patent foramen ovale. Some other congenital heart defects, things you're born with, you can have what's called VSD, which is ventricular septal defect. And this, instead of having that patent foramen ovale, which is supposed to be there, you're supposed to have a hole between your atrium until it closes. This is going to be a hole between the ventriculars, in the ventricular septum, between the ventricles. And this occurs about 1 in every 500 births. And just like a patent foramen ovale, you're going to get mixing of oxygenated and deoxygenated blood. So what happens is you're going to be pumping, and the left side of deoxygenated blood is entering into the left side. You're going to be pumping poorly oxygenated blood, mixed blood in your aorta. All right. What typically happens if it's not treated is because the left side's got the bigger heart wall, bigger muscle. It's stronger, so it tends to shunt more blood from the left side to the right side. So you're shunting a lot of this blood into this side, and so it kind of decreases the pumping efficiency, the ability for the blood to pump out the aorta. It's easier if you think about the ventricle contracting. Instead of pushing the blood up, it kind of pushes it over. All right, so you'll see more shunting of the blood from to the left to the right side, which can cause problems, obviously. You can have coarctation of the aorta, which means narrowing. That's just all that means. So a narrowed aorta, and so that's not good because that means your left side has to work harder. It's like you've put a constriction band around the aorta, so now the ventricle has to work really hard to pump that blood through the aorta. So that can cause problems. That has to be repaired. Tetralogy of Fallot, that means there's 4 things, and I guess this was the guy's name who discovered it. You have a pulmonary trunk that's too narrow, okay, or possibly pulmonary valve stenosis, which means the right ventricle is going to have to work too hard to pump blood out that way. You have a hypertrophied right ventricle because it's working so hard to pump blood out the pulmonary trunk. You have VSD, which means the left side is forcing more blood into the right side, causing it to be over-distended and having to work harder. and you have an aorta that opens into both ventricles. All right, so now because the right side is working harder, it's going to be pumping this poorly oxygenated blood into the aorta just like the left side does. So you're going to have increased deoxygenated blood, poorly oxygenated blood traveling through the aorta into the rest of the body. So these are things that will require surgery to be repaired. And depending on, some heart defects, depending on the problem, may require a heart transplant. But they're doing more and more things now surgically to repair these kind of birth defects. And then the last one is called hypoplastic left heart syndrome. This is one where hypoplastic really means too small. And so if you'll notice, here's the right ventricle. This is the left. Look how small. So hypoplastic left heart. They have a really, really small left ventricle. And so that has no pumping power at all. And so it's pumping, and it's going to not be able to pump blood through the aorta, and so you're not going to be able to perfuse the tissue. I have a personal connection to this particular one because I had a child born with hypoplastic left heart. And so what happens when they're first born, some of those physiologic changes that are supposed to cause the ductus arteriosus to close will allow it to stay patent. And so the child will usually survive for a couple of days because the right side of the heart is going to pump, and it's going to be pumping blood into the pulmonary trunk, and it's going to provide the blood that needs to go to the aorta. And so it's doing the work of both sides. And so the child may live anywhere from 24 hours to a week until eventually that ductus arteriosus will finally just close and fail. And the right side, because it's having to do the job of both sides, finally fails. And so they go into heart failure. So this particular one, they're doing some surgeries to try to fix it, but they're also doing complete heart transplants. Unfortunately, we did not know in time, so there was nothing that could be done for my child. But this is one that you may hear about, hypoplastic left heart, where basically the right side of the heart is having to do the work for both sides. And again, the child will live as long as that ductus arteriosus stays open, but eventually it will close and then death will result. So that's just one of those things that are interesting, and I have a personal story, so I like to share that. Let's see. That's it. That's all I'm going to talk about today. So make sure you go back and really think about the differences between adult circulation and fetal circulation. There may be some kind of compare and contrast. Make sure you understand those key differences, vascular shunts, between the adult and fetal circulation. All right, that's it. Thanks a lot.